Disorders that cause upper GI bleeding in adults. Disorders that cause upper GI bleeding in adults can be divided in 6 categories. Ulcerative or erosive. Complications of portal hypertension. Vascular lesions. Traumatic or iatrogenic. Tumors. Miscellaneous. GI bleeding due to ulcerative or erosive causes can be due to duodenal and/or gastric ulcer, esophagitis, gastritis or gastropathy or duodenitis or duodenopathy, duodenal and/or gastric ulcer. Bleeding manifestations. Hemosuccus. Melena. Hematochezia, indicates brisk bleeding. Occult blood loss. Associated signs and symptoms. Upper abdominal pain. Pain associated with eating, worse when eating suggests gastric ulcer, improvement with eating suggests duodenal ulcer. Dyspepsia. Associated conditions or risk factors. Infections, Helicobacter pylori, cytomegalovirus, CMV, herpes simplex virus, HSV. NSAIDS. Stress ulcer, for example in patients who are critically ill. Excess gastric acid production, Zollinger-Ellison syndrome ZES. Idiopathic. Endoscopic findings. Ulcer with smooth, regular, rounded edges, ulcer base often filled with exudate. Examination of the ulcer may reveal active bleeding or oozing. Non-bleeding visible vessel. Adherent clot. Flat pigmented spot. Clean ulcer base. Esophagitis. Bleeding manifestations. Hemosuccus. Melena. Occult blood loss. Associated signs and symptoms. Dysphagia or odynophagia. Retrosternal pain. Food impaction. Associated conditions or risk factors. Gastroesophageal reflux disease. Medications. Tetracycline. Doxycycline. Clindamycin. Trimethoprim sulfamethoxazole. NSAIDS. Oral bisphosphonates. Potassium chloride. Quinidine. Iron supplements. Infections. HSV. CMV. Candida albicans. HIV. Endoscopic findings. Erythema, mucosal breaks or erosions, exudative lesions, superficial or deep ulcers, stenosis, scarring. Peptic esophagitis, the ulcerations are usually irregularly shaped or linear, multiple, and distal, may be accompanied by Barrett's esophagus. Pill-induced, ulcerations are usually singular and deep, occurring at points of stasis, especially near the carina, with sparing of the distal esophagus. Infectious esophagitis. HSV, discrete, superficial ulcers, with well-demarcated borders that tend to involve the upper or mid-esophagus, vesicles may be seen. CMV, ulcers range from small and shallow to large, greater than 1 cm, and deep, most patients have multiple lesions. Candida, diffuse white plagues. HIV, tends to involve the mid to distal esophagus, ulcers may be shallow or deep, and may be large. Gastritis, gastropathy, duodenitis, and duodenopathy. Bleeding manifestations. Occult blood loss. Hemosuccus. Melena. Associated signs and symptoms. Dyspepsia. Associated conditions or risk factors. H. pylori. NSAIDS. Excessive alcohol consumption. Radiation injury. Physiologic stress. Weight loss surgery. Bile reflux. Risk factors for bleeding, anticoagulant use. Endoscopic findings. Erythematous mucosa. Superficial erosions. Nodularity. Diffuse oozing. Complications of portal hypertension. Esophagogastric varices. Ectopic varices. Portal hypertensive gastropathy. Esophagogastric varices. Bleeding manifestations. Occult blood loss. Hematmesis. Melena. Hematochezia, indicates brisk bleeding. Associated signs and symptoms. Stigmata of chronic liver disease, in particular, signs of portal hypertension, splenomegaly, ascites, thrombocytopenia. Associated conditions or risk factors. Portal hypertension from cirrhosis. Portal vein thrombosis. Non-cirrhotic portal hypertension. Endoscopic findings. Vascular structures that protrude into the esophageal and/or gastric lumen. Esophageal varices. Gastric varices. Ectopic varices. Bleeding manifestations. Hematmesis. Melena. Hematochezia, indicates brisk bleeding. Associated signs and symptoms. Stigmata of chronic liver disease, in particular, signs of portal hypertension, splenomegaly, ascites, thrombocytopenia. Associated conditions or risk factors. Portal hypertension from cirrhosis. Portal vein thrombosis. Non-cirrhotic portal hypertension. Endoscopic findings. Vascular structures that protrude into areas of the gastrointestinal tract lumen other than the esophagus or stomach, for example, small bowel, rectum. Portal hypertensive gastropathy. Bleeding manifestations. Occult blood loss. Hematmesis. Melena. Hematochezia, indicates brisk bleeding. Associated signs and symptoms. Stigmata of chronic liver disease, in particular, signs of portal hypertension, splenomegaly, ascites, thrombocytopenia. Associated conditions or risk factors. Portal hypertension from cirrhosis. Portal vein thrombosis. Non-cirrhotic portal hypertension. Endoscopic findings. Mosaic-like pattern that gives the gastric mucosa a snakeskin appearance. Mucosal changes are usually most evident in the fundus and body, in more severe cases, oozing, bleeding, subepithelial hemorrhages, and increased vascularity similar to angiomas are evident, often involving the gastric fundus, gastric body, and antrum. Vascular lesions. Angiodysplasia. Dieulafoy's lesion. Gastric antral vascular ectasia, GAVE. Blue rubber bleb nevus syndrome, Bean syndrome. Angiodysplasia. Bleeding manifestations. Hematmesis. Melena. Hematochezia. Occult blood loss. May have brisk bleeding. Associated signs and symptoms. Cutaneous angiodysplasia in patients with hereditary hemorrhagic telangiectasia, Osler-Weber-Rondeau syndrome. Associated conditions or risk factors. End-stage renal disease. Aortic stenosis. Left ventricular assist device. Hereditary hemorrhagic telangiectasia. Von Willebrand disease. Radiation therapy. Idiopathic. Endoscopic findings. Small, 5 to 10 mm, flat, cherry red lesions, often with a fern-like pattern of arborizing, ectatic blood vessels radiating from a central vessel. Dieulafoy's lesion. Bleeding manifestations. Hematmesis. Melena. Hematochezia, indicates brisk bleeding, bleeding is often particularly brisk. Associated conditions or risk factors. Etiology unknown. Bleeding may be associated with NSAIDs, cardiovascular disease, hypertension, chronic kidney disease, diabetes, or alcohol abuse. Endoscopic findings. Usually located in the proximal stomach, within 6 cm of the esophagogastric junction, along the lesser curvature, although can be found anywhere in the GI tract. May have active arterial spurting from the mucosa without an associated ulcer or mass. If the bleeding has stopped, there may be a raised nipple or visible vessel without an associated ulcer. Endoscopic ultrasound may help confirm the diagnosis. Gastric antral vascular ectasia, GAVE. Bleeding manifestations. Hematmesis. Melena. Hematochezia, indicates brisk bleeding. Occult blood loss. Associated signs and symptoms. In patients with cirrhosis, there may be stigmata of chronic liver disease, in particular, signs of portal hypertension, splenomegaly, ascites, thrombocytopenia. Associated conditions or risk factors. Idiopathic. Cirrhosis with portal hypertension. Renal disease/transplantation. Diabetes mellitus. Systemic sclerosis, scleroderma. Bone marrow transplantation. Endoscopic findings. Longitudinal rows of flat, reddish stripes radiating from the pylorus into the antrum that resemble the stripes on a watermelon. Blue rubber bleb nevus syndrome, Bean syndrome. Bleeding manifestations. Hematmesis. Melena. Hematochezia, indicates brisk bleeding. Occult blood loss. Associated signs and symptoms. Venous malformations and hemangiomas of any organ, including skin, central nervous system, liver, muscles, lymphatics. Intussusception. Endoscopic findings. Blue or purple nodules, round or multilobular, may occur anywhere in the gastrointestinal tract. Traumatic or iatrogenic causes. Mallory-Weiss syndrome. Foreign body ingestion. Post-surgical anastomotic bleeding, marginal ulcers. Post-polypectomy or endoscopic resection or endoscopic sphincterotomy. Cameron lesions. Aortoenteric fistula. Mallory-Weiss syndrome. Bleeding manifestations. Hematmesis following an increase in intra-abdominal pressure. Melena. Hematochezia, indicates brisk bleeding. Associated signs and symptoms. Epigastric pain. Back pain. Associated conditions or risk factors. Vomiting or retching, often related to alcohol consumption. Straining at stool or lifting. Coughing. Seizures. Blunt abdominal trauma. Hiatal hernia may increase the risk of developing a tear. Endoscopic findings. Tear in the esophagogastric junction. Usually singular and longitudinal, but may be multiple. Visualization may require retroflexion of the gastroscope in the cardia of the stomach. The tear may be covered by an adherent clot. Foreign body ingestion. Bleeding manifestations. Hematmesis. Melena. Hematochezia, indicates brisk bleeding. Occult blood loss. Associated signs and symptoms. Dysphagia. Duodenophagia. Neck or abdominal pain. Choking. Hypersalivation. Retrosternal fullness. Associated conditions or risk factors. Psychiatric disorders. Dementia. Loose dentures. Endoscopic findings. Visualization of the foreign body endoscopically. Plain radiographs of the neck, chest, and abdomen may reveal a radiopaque foreign body or signs of perforation. Post-surgical anastomotic bleeding, Marginal ulcers. Bleeding manifestations. Occult blood loss. Hematmesis. Melena. Hematochezia, indicates brisk bleeding. Associated signs and symptoms. Epigastric pain. Nausea. Associated conditions or risk factors. Billroth 2 surgery. Gastric bypass surgery. NSAID use. H. pylori infection. Smoking. Endoscopic findings. Ulceration or friable mucosa at an anastomotic site. Post-polypectomy or endoscopic resection or endoscopic sphincterotomy. Bleeding manifestations. Hematmesis. Melena. Hematochezia, indicates brisk bleeding. Associated signs and symptoms. Past history of instrumentation, may be as long as 3 weeks prior to presentation. Associated conditions or risk factors. Large lesions. Endoscopic findings. Bleeding at resection site, ulceration at the site may be seen. Cameron lesions. Bleeding manifestations. Occult blood loss. Hematmesis. Melena. Hematochezia, indicates brisk bleeding. Associated conditions or risk factors. Hiatal hernia. Reflux esophagitis. Endoscopic findings. Linear ulcers or erosions on the mucosal folds of a hiatal hernia at the diaphragmatic impression. Aortoenteric fistula. Bleeding manifestations. Hematmesis. Melena. Hematochezia, indicates brisk bleeding. May have a herald bleed followed by massive bleeding. Associated signs and symptoms. Back pain. Fever. Signs of sepsis. Pulsatile abdominal mass. Abdominal brood. Associated conditions or risk factors. Infectious aortitis, syphilis, tuberculosis. Prosthetic aortic graft. Atherosclerotic aortic aneurysm. Penetrating ulcers. Tumor invasion. Trauma. Radiation injury. Foreign body perforation. Endoscopic findings. Endoscopy is important, primarily to exclude other, more common causes of acute upper GI bleeding. Endoscopy with an enteroscope or side-viewing duodenoscope may reveal a graft, an ulcer, or erosion at the site of an adherent clot, or an extrinsic pulsatile mass in the distal duodenum or esophagus. Tumors. Upper GI tumors. Upper GI tumors. Bleeding manifestations. Hematmesis. Melena. Hematochezia, indicates brisk bleeding. Occult blood loss. Associated signs and symptoms. Weight loss. Anorexia. Nausea/vomiting. Early satiety. Epigastric pain. Dysphagia, for tumors in the esophagus or proximal stomach. Gastric outlet obstruction. Palpable mass. Paraneoplastic manifestations. Diffuse seborrheic keratosis. Acanthosis nigricans. Membranous nephropathy. Coagulopathy. Associated conditions or risk factors. Virtually any tumor type may bleed. Benign tumors. Leiomyoma. Lipoma. Polyp, hyperplastic, adenomatous, hamartomatous, inflammatory. Malignant tumors. Adenocarcinoma. GI stromal tumors. Lymphoma. Kaposi sarcoma. Carcinoid. Melanoma. Metastatic tumors. Endoscopic findings. Ulcerated mass in the esophagus, stomach, or duodenum. In gastric malignancies, the folds surrounding the ulcer crater may be nodular, clubbed, fused, or stop short of the ulcer margin, the margins may be overhanging, irregular, or thickened. Bleeding lymphoma may appear as an ulcerated mass or polypoid lesion or as a gastric ulcer. Miscellaneous causes: Hemobilia, Hemosuccus pancreaticus, Hemobilia. Bleeding manifestations: Hematmesis, melena. Hematochezia, indicates brisk bleeding. Associated signs and symptoms: biliary colic, jaundice, obstructive, sepsis, biliary. Associated conditions or risk factors: past history of liver or biliary tract instrumentation and/or injury, including the following: liver biopsy, cholecystectomy, endoscopic biliary biopsies or stenting, TIPS placement, angioembolization, blunt or penetrating abdominal trauma, gallstones, cholecystitis, hepatic or bile duct tumors, intrahepatic stents, hepatic artery aneurysms, hepatic abscesses, endoscopic findings, blood or clot emanating from the ampulla. A side-viewing duodenoscope may be required to visualize the ampulla. If a clot has formed in the bile duct, bleeding may not be appreciated until the clot is removed. ERCP may reveal a filling defect in the bile duct. Hemosuccus pancreaticus. Bleeding manifestations: hematmesis, melena. Hematochezia, indicates brisk bleeding. Associated signs and symptoms: abdominal pain. Past evidence of symptoms/signs of pancreatitis. Imaging evidence of pancreatitis, current or in the past. Elevated amylase and lipase, current or in the past. Associated conditions or risk factors: chronic pancreatitis, pancreatic pseudocysts, pancreatic tumors, pancreatic pseudoaneurysm, therapeutic endoscopy of the pancreas or pancreatic duct, pancreatic stone removal, pancreatic duct sphincterotomy, pseudocyst drainage, pancreatic duct stenting, endoscopic findings, blood or clot emanating from the ampulla. A side-viewing duodenoscope may be required to visualize the ampulla. Cross-sectional imaging or angiography is often required to confirm the diagnosis. Thank you for watching this presentation. Please subscribe to my channel for more such presentations.